Okay, great. We're very pleased to have with us our guest, as our guest today, the Executive Director of the Stop TB Partnership, Dr. Lucica Ditiu. And she's here to brief you on the global impact of tuberculosis, including in conflict areas. Ms. Ditiu, thanks very much for coming. The floor is yours.
Thank you so much. I don't need to press anything. This works and very sophisticated. So good day to everyone, and really thank you for taking the time to be here, and more especially thank you to Farhan and the team for hosting us here. I am the Executive Director of the Stop TB Partnership. We are a United Nations hosted entity. We aim to end tuberculosis. That I don't know how many of you are aware that in spite of the fact that is with us for hundreds of years, is the biggest infectious disease killer, killing more than HIV and malaria together, and currently more than COVID. Is actually around 4,400 people every day, 700 are children. And before COVID, I think we were going well in terms of getting closer to reaching the ending of TB, but then COVID, and now the entire situation that is currently in the world is impacting a lot what happens with TB. So, TB is a disease, as you know very well. I hope most of you read and saw Les Miserables, for many years, we didn't see very dramatic cases of TB, but after COVID, we saw a type of TB that we saw in this type of movies, in which people spit blood and they are very weak and so on. And the current situations now with the economy going in all different directions, and the conflicts that we see, first obviously the war in Ukraine, but even the fight now in Sudan, is having a huge impact on our efforts to try and end TB. During the war in Ukraine, it's remarkable the fact that the Ukrainian people are actually showing an amazing resilience in doing their best to maintain the services for TB. But obviously a lot of people left the country, and there is a lot of effort ongoing to ensure that, especially for TB, in which it's very important to diagnose the disease early because it's airborne, right? So it's spread through air. So, and everyone is at risk. So you need to find the people early and get them diagnosed. And then we need to make sure that the treatment is followed up. So in the context of people moving around, which is not just Ukraine, Sudan is another hot spot there, and there is a lot of TB HIV in Sudan, and all the situation now is probably like a ticking bomb in terms of some of the health threats. So, but as I was saying, it's remarkable the efforts, at least in the Ukrainian side, in trying to contain and maintain the services for people with TB. And we worked with several other partners to secure and ensure that across the border, there is a communication in terms of making sure that people are not being lost, especially the people with TB. So the presence that I have here is not only to do the briefing, even though this is very important, is that in September there will be a UN high-level meeting on tuberculosis. There are 3 meetings on health, one on universal health coverage, one on pandemic preparedness, and one on tuberculosis. For TB, this is the second one. There was a first one in 2018. And we expect that this year we hope actually to have a very strong political declaration and a very strong presence of the leaders around tuberculosis and commitments, hopefully, to go and see that we can end it by 2030. It's a bit paradoxal what I'm saying, because on one hand I'm saying this is the biggest infectious disease killer. It kills so many people. We have resistant forms. It's airborne. The resistant forms obviously are also spread through air. And in the same time I say that we can end it by 2030. And that's because we have 3 things that I think are very important for TB currently. We see a lot of energy in the research space. I think TB is at the front line in using digital health and artificial intelligence in the TB response. Even just to give you an example, we don't have yet anything in Sudan, but in Ukraine, we were able to push mobile X-rays. In my lifetime, TB X-ray was done in a room. You know, we go in a room and everyone close the door. It's a big door. Everyone runs out of the corridor because of radiation. Now there are mobile X-rays that you can even take a selfie with it. It's very small. It's portable. So it was used a lot in Ukraine to do mobile screening. Even last year, I mean, even during the starting, I think early April, we were able to send some of these tools there. So there is a lot of hope in the research platform, in the research area for TB, including the perspectives of having a vaccine. There is no disease that can be ended without proper prevention, and especially a vaccine. And in tuberculosis, we don't have a vaccine that works in adolescents and adults, so it's good to have some things at the end of the tunnel there. But also there is a renewed energy because we have a lot of civil society and communities, and we have a lot of people from the country level that created platforms and networks to really demand for more at national level on that. And actually, Monday, we have a multi-stakeholders hearing on TB, Monday afternoon. And we as Stop TB brought together with partners around 150 civil society and communities from all high-burden countries that are here with us in New York, and basically taking the missions of their countries by is not really an assault in the real sense, but something like that. So basically, they go to visit their ambassadors and their missions here and discuss about tuberculosis, because very often, unfortunately, TB is very forgotten. It's not a very sexy disease. It affects the most vulnerable people. During COVID, we saw that behind these big statements of solidarity, when the crisis hits the ground, everything is my toys are my toys, your toys are your toys, and the collaboration doesn't really work very well. And TB, because it affects usually people in the low-income countries with a lot of vulnerabilities, is not necessarily the darling of those that are looking for big money to be made. So because of that, there is a bit of silence in there. So I'm very honored to have a chance to share these few thoughts with you. And I hope you can follow and write some of these stories. As I said, there are 150 communities and civil society people here in New York these days, up to 10, 11 May. Going left and right, I just visited the Brazil mission. People are now in Zambia and Zimbabwe missions, and Canada and so on. And the last thing that I want to say is that we developed a set of kiosks that will be the ideal scenario to really put TB on track to be ended by 2030. Not to be eradicated, that will not happen in our lifetimes, even of the youngest ones, not to be eliminated, which means 1 case per million, but to be ended, which is basically countries to take a cutoff point and to decrease their current incidence to the lowest levels. For example, India, which is the highest burdened country in the world, will probably choose a level of around 60 per 100,000 as an ending for TB, because they come from a long way, more than 200 per 100,000. The last thing that I want to say is that we can go a long way, and this is the last thing that I'm leaving you with, because ultimately we are all human beings. If there is something that you can leave from here, is to still realize that in spite of being a disease that is with us for hundreds of years, TB is still here. And it puts all of us at risk. I am infected with TB. I'm not sick, I am infected, and I don't know where I got it. I live in Switzerland, but I obviously go a lot to countries to visit. And the moment you realize you are infected and you know you carry it with you, and at the moment when you either your immune system is affected, or I don't know, some other things can impact us, and I can become sick. I tell you that it's very worrying, because you never know if it's TB or it's drug-resistant TB and so on. So it's we can protect ourselves for many diseases, right? We can eat well, we can run, we can do protected sex, we can take PrEPs and others, we can sleep under a bed net, but we cannot really protect the air. And COVID showed us that airborne diseases are bad and are probably what will be the next pandemic. And when COVID hit the road, the TB doctors and the TB hospitals were the first ones to deal with COVID in the big parts of the world, because they were the ones dealing with the lungs. So that's why TB is a very present conversation on the pandemic preparedness, response as well, agenda, and so on. But I know time is short. I tried to go in a bit of a roller coaster with a lot of information for you. The least we can get from here is you as human beings realize that TB is still here. To be honest, this morning, the ambassador of Brazil here said something very wise. He said, I feel embarrassed that we were able to address COVID so quickly, transform it in a kind of flu. HIV is becoming a chronic disease, but we have tuberculosis that it's for hundreds of years now, and we know how to treat, and we have treatment, and we are still unable to do a deep in it. So thank you so much for this, and very happy to be here. Thank you.
Thank you very much, Ms. Ditiu. I'll turn the floor over to questions. Edie?
Thank you very much, Doctor, for doing this briefing on behalf of the United Nations Correspondents Association. Welcome. My name is Edith Lederer from the Associated Press. You mentioned both Ukraine and Sudan. Do you have figures for how many TB cases there are in both countries, which would give some, before the conflicts, which would give some indication of how many people now have problems? And the high-level meeting, is that going to be on the margins of the meeting of world leaders in late September, and is there a date?
Yes. So I'll start with the easiest and shortest one, which is the UN high-level meeting is on 22nd of September, which is the Friday of the Anga week. So it will be a very crowded space, as we know, with so many competing priorities. And the fear that we have is because TB is not that much in the face of leaders, you know, and being a Friday, there is an uphill push there to make sure that we had the right presence. So I will send you the Sudan data because I don't have them by heart, but because I am Romanian and we were very much involved in the Ukrainian story, the number of Ukrainian people with TB is very high. Actually, it's the highest number in entire Europe and the region, 34,000 people with tuberculosis. In the same time, estimated figure. In the same time, they had a large number of people with drug-resistant TB as well in Ukraine. Now, the very good thing is because together with WHO and the Global Fund, there was from the beginning a system in place to make sure that people are tracked and really clear. We know that there were less than 200 people that with MDR-TB that were moved out of Ukraine to Moldova and Romania, but we don't have the figures for the normal TB, not MDR-TB. The thing that happened, so these are the figures basically. Ukraine was the highest burden country with TB in the European region, as we call it, in there. But what was, I think, remarkable was the fact that, as I said, people were traced, at least for the follow-up of the treatment. What I think is what worries everyone is to ensure that people will have access to be diagnosed, people that remained in Ukraine. And it's not because the health staff is not there, because they are doing amazing things. And I'll just share with you something. We have two amazing ladies from Ukraine with us here. It took them a lot of time to reach us. They came from Moldova, through Moldova, and their families are in Kiev. So this morning we had some emotional moments in seeing what's happening with the bombing there. But what I wanted to say is that I tell you, as human to human, the resilience, it's unbelievable. We were having calls about TB in Ukraine just to, to make sure that there is no loss to follow up, we call. Like if somebody starts the treatment, you need to make sure you ended up, otherwise you develop resistance. And things were already in place and people thought about that. And we were having calls and people were joining from their cars and from their shelters to discuss about TB. You know what I mean? And I was saying, if we would have the same in every single country, we have countries in which there is no war, things are fine, and it's still less commitment. And these people, so it's that is what is absolutely spectacular in that. Thank you.
Thank you. Excuse me. Evelyn Leopold. You mentioned HIV, and is part of the, is the United States still doing PrEPFAR and so forth? And is part of the problem is that gays and transsexuals are not considered part of the plan?
Actually, HIV is a big risk for TB, but it's basically this, what I was, so if I get HIV, I will very likely become sick, speaking about the fact that I'm infected. So HIV is responsible, when people have TB, HIV, from the entire burden of TB, 11% is because of TB, HIV globally. So that's the risk of the co-infection. In the African region, it goes as far as 70%. So it's TB, HIV is a big issue. Now, HIV, because of the treatment and the PrEP and so on. So first of all, transmission is much less. And also because of the treatment, HIV per se is like a chronic disease. You just need to monitor the treatment, side effects, and so on. But TB is the biggest killer of people living with HIV. 1 in 3 people dying, people living with HIV dying, are dying because of TB. So it gets very complicated forms, and people need to have access immediately to diagnosis and treatment. You know, it kills very quickly, unfortunately, in people living with HIV. I'm speaking globally, not in US. So in Africa, a big challenge with TB, because it's, and people living with HIV with TB, is to get diagnosed. People don't have access, because just to give you a picture, basically we estimate in the world 10 million people with TB. Out of that, in 2021, only 6 million were diagnosed and treated. 4 million are what we call them missing people with TB. That means they are somewhere here. They are people living with HIV or other vulnerabilities that don't have access to diagnosis and treatment. And they suffer, but they also spread the disease to others, unfortunately. And this is the drama. So the response to TB actually includes very well the vulnerable groups, including gay, including transgender. It includes it in documents and in the paper. I don't think there is a big neglect in terms of gay, but I think transgenders' access to services. I don't know particularly in US, to be honest. I know a lot in the high-burden countries, but for transgenders into high-burden countries, low-income countries, it's really difficult, the access. It's like with everyone with a vulnerability. You know, the services are not friendly and welcoming enough. There is a fear to really address them and so on. We funded a Stop TB, a project, very interesting, with transgender in Pakistan. I mean, like, imagine. And which were in charge exactly that, to try and find in their community people with TB. And they identified 4 times more than what they even expected to have, not what was it was incredible what was done. And it actually was not any silver bullet. They say, okay, what did you do? Nothing. We just facilitated that the services are welcoming people to do what they are designed to diagnose them. So the programs are including, and I think for the men having sex with men communities, it's not as easy or without barriers as it should be, but it's much better. But from transgender is much more difficult.
Stefano.
Thank you, Stefano Vaccara, Voce di New York. Thank you for your presentation. You say that, well, you told us the TB kills more than COVID and killed more than COVID and HIV combined. And you also explained why do you think is still around us so much, because there has not been in so many years the same kind of investment, right?
Yes.
So we are the journalists. We should spread what you just said. If you were in charge to do a headline now, tomorrow, for the New York Times of tomorrow, what will be your headline to shake a little bit who controls this investment, a big pharmaceutical company, anybody that should do something different that has been done in I would say, many years?
Yeah. It's a good one, not because we miss possible headlines, but because there are many headlines. And I will just tell you three. One overarching one is the fact that I think a good headline is, it comes from, it's not necessarily the headline itself that I'm giving, but a group from us, we funded and went to London on the streets with a camera and met people and discussed with people on the street and said, it was before COVID, it said there is a disease that is spread through air that is a lot in UK and London that you all can get. And by the way, tuberculosis, untreated. So if somebody has TB and doesn't treat, says, I don't care, I will just ignore it. 50% of people die. So it kills. It doesn't kill spectacularly like COVID in a few weeks. It kills your lungs. It's basically what it does is create initially a nodule. The nodule grows and then creates a cavity. And the cavity, the bleeding comes from the fact the cavity eats the blood vessels, right? So actually it eats your lungs. It's like a sponge in which that hole in the sponge grows. So when people went on the street and said that, everyone freaked out from the people on the streets. And then the people said, okay, but what is this disease? And they said TB. And they're like, but TB we know, it's okay, you know? So I think the headline is, the world is still having it has an airborne pandemic that it ignores. And it knows how to treat, and it has the treatment, and is very cost efficient, but it ignores. So something along the line that the embarrassment of the world, ignoring another airborne pandemic that was here for hundreds of years, but paying no attention. That's one. The other possible headline in my head, I am a parent. When I was, I found out that I'm infected with TB. I freaked out because in the same time my son was coughing a lot. So I worried because, you see, TB is bad, but drug-resistant TB is very bad because the treatment is very toxic, right? So it gives a lot of side effects. So, and it's not pleasant. And, you know, it depends on what kind of resistance you have. You might not even have all the drugs. So I really freaked out. So I think what happens now, and nobody realizes, 700 kids a day die because of TB. And kids don't spread the disease. So they don't share it with us, but they get it from an adult. So that's the sign. If in a country, you don't need even to write, but you go in a country and you find out there are a lot of kids with TB, it means there are many more adults with TB than them. So the other headline is that we kill our people. We kill our children. We kill our children. We, the adults, kill our children with TB because we ignore it, we don't do anything for it, and it's so easy to do. And the third one is a sort of something that, you know, when you have, you know, as I said, for TB, it took 19 years to the research community to go to a pipeline in which we have 3 or 4 vaccines that are promising. We are not yet there with them, but because of, not because people are stupid and they are not able, but because of the lack of funding. It took 19 years to arrive at phase 3 trials, okay? In 2021, for TB vaccine development was available, or in 2020, sorry, it was available $100 million, and it was $100 billion for the COVID vaccine. You know, it's so many more times. So the other headline is that, you know, around the fact that in the TB world, we are still working with a 100-year-old vaccine that is not even efficient on adults. In TB, some of the tools that are now in place is not only the 100-year-old vaccine. Around 40% of people with TB in the world today are diagnosed with the same tool that was used by Robert Koch in 1896 with the microscope. And it's not because we don't have the tool, it's because we don't have the money. So it's a crime to diagnose, none of us here, at least from this group, will accept to be diagnosed by a microscopy because the microscopy just, you look, First of all, you have to produce the sputum. You look, and you find out that you have TB, but you don't know if it's active or if it's resistant. So you start a treatment kind of the best guess. The real tool, which is WHO recommended, that people like us and are having, is a tool that says, yes, it's TB, is alive, is resistant to this, so you take this better treatment. But 40% of people in the world are diagnosed like if Robert Koch comes from the grave, he'll be comfortable in the diagnosing of TB. He will freak out with the cars and the phones and stuff, but with TB, put him in a lab, he'll be perfect fine. He'll be like, oh my God, I'm back in my world. So this is a crime, right? You see that for a disease that, another title that is very provocative is to say why the world pays zero attention to COVID. Is it because it affects the most vulnerable and there are no money that are coming out of it? Because that's what it is. It's not our problem. It's their problem. They are different than me. I don't care. So, yeah, thank you.
Yes, Edie?
Could you tell us a little more about these 3 or 4 vaccines? Are any of them mRNA?
No, but that's a very good question. Thank you. No, they are because they come from some time ago. With some of them, Gates and Glaxo are moving, and they are entering into the phase 3 clinical trial. Is called M72. This one, but it will take time because it's not an mRNA. However, the BioNTech people and few others are looking into using mRNA for a TB vaccine. And even more, the multi-stakeholders hearing Monday, actually the CEO of BioNTech will speak. And we hope that they will enter into pushing. So there is already preliminary research on this, and that will be the only way for us to get a vaccine in time to roll it a bit before 2030 to have a big impact. Because what the data show is that, okay, it will be great, but if we get a vaccine in 2029, it will save lives, but it will not be like, it will make a big impact by 2030. So the ideal scenario is to get a vaccine by 2025, to roll it out 3-4 years, that before 2030, we see the numbers driven down. The science is feasible. Is the money and the attention, and it's not even that much. It's like $2 billion to have for the vaccine, to see all these vaccines that are currently in the phase 3 seeing the light, and see, and use maybe a combination of them, because I don't think there is any of them like the silver bullet, like to say you take this and you are there.
Okay, I don't see any further questions, so I'd like to thank Dr. Ditiu. Again, thanks for this very worrying, actually, briefing.
Thank you.
But thank you for coming, and thanks for everything.
No, I want to thank you for listening to us, and I want to thank you because people need to know. And unfortunately, I think because it's not a sexy topic, people forget about it. And new things are coming, and we forget about the things that exist. And now we have the PPR, and everyone speaks about new things spread through air. But when, as I said, COVID happened, everyone ran to the TB hospital, doctors, TB labs, because they were the only ones with infection control measures and stuff like this. So be smart. Don't run after just the new ones. Think of the old ones as well. But anyway, thank you so much. Thank you, really.
Okay. Thank you very much, and please stay in the room. We'll have now the spokesperson for the President of the General Assembly, Paulina Kubiak.
Thank you so much. Thank you very much. Thank you.